Ooh, hopefully everyone can see that.
I can. Sorry, I've unmuted.
That's all right, thank you. It's like, it's just me here. So
No.
Cheryl, do we need to wait, or do you want me to kick off, or what do you want me to do?
You can carry on, Dan. I think that's it now.
Yeah, okay, fine.
Cheers.
That's okay. Hi everyone. Right, I think you all know me. So I'm Dan. I'm one of the consultants. So Cheryl had asked that I do a presentation, a bit of talk about asthma and how we manage asthma on the wards. So it'll probably just take about half an hour. I was just going to talk a bit about asthma and what it is, and then go through our All Wales asthma guideline, and just talk through about why it says what it does, and what the trainees should be doing, so that you can help guide them, because sometimes they need a bit of help. So if anyone's got any questions, do ask as we go along, or wait to the end and then ask, or like last time, just remain silent throughout. No one said anything. That's fine. Right. So managing a child presenting with asthma attack. So what is asthma? Asthma is a chronic respiratory condition. So that means, long term, it doesn't just come and go, it's there the whole time. And it's associated with airway inflammation and hyperresponsiveness. So that's swelling of the airways, and they're really easily irritated. And it's all an excessive immune response. So people with asthma have an immune response in the airways that isn't like other people's, and it's a bit excessive. So any kind of irritant, you or I might walk behind someone who's smoking and cough a bit. Somebody with asthma, actually their lungs would react to that smoke much more readily and more severely, causing lots of irritation and changes in their airways. It's really changeable and very variable. So, you can have two people with both two children with asthma, one who's in hospital all the time and one who's not. But then you can also have a person who's really well controlled most of the time and will suddenly have a significant asthma attack. So it is very variable. And it's characterized, the key features that happen, we all know symptoms of asthma: cough, wheeze, chest tightness, and shortness of breath. So how common is it? Well, it's really common. So, in the world, there's millions of people, and it probably about 1 in 10 kids around the age of 6 and 7 have got asthma. So, that's a few kids in every class. And in the UK, they say there's about over 8 million people, that's adults as well. And approximately 12% of the population have had a diagnosis of asthma. Some have grown out of it. We used to talk about childhood asthma, and we don't really do that anymore. But there's still 5 and a bit million people receiving asthma treatment. And in early childhood, it's more common in boys. So I think that probably is what we see. We see more boys coming in with wheeze. But then as you get older, it tends to switch. So in adulthood, it's more common in women. And asthma, just accounts for loads and loads of healthcare usage. So about 2 to 3% of GP appointments, 60,000 hospital admissions, 200,000 bed days. This is adults as well, but it's a big proportion of what the NHS spends its money on. So what causes asthma and who's most at risk? It's caused by loads of different factors. So, you'll hear us talking on the ward and asking about risk factors. The biggest risk factor for asthma is if mum's got asthma. So there is an increased risk if dad's got asthma, or brothers and sisters, or aunties or uncles, but the biggest risk factor is maternal asthma. So if mum's got asthma, there is a much higher risk that the children will have asthma. And also we talk about atopic tendencies. This is a genetics that make you more likely to have allergic conditions. And by that we mean asthma, eczema, hay fever, and food allergies. So we'll often ask about those things just because it gives us an idea of how likely we think someone might have asthma, or maybe they've just had a virus and it's just irritated their chest. So respiratory infections in infancy, all these kids with bronchiolitis, it's a whole nother talk in itself, but does bronchiolitis cause asthma? The answer is probably no, because most kids who have bronchiolitis never have a problem when they're older, but there are a proportion of kids that get particularly rhinovirus when they're around 4 months old, that then have a much higher risk of getting asthma. So it may be something to do with the immature immune system then getting hit by a respiratory virus in somebody whose genetics predispose them to asthma, that actually means they then get more symptoms as they get older. More common if you're premature, cigarette smoke. So we always have to ask about smoking. social deprivation, the poorer you are, the worse your health. So it's much more common in people from poorer backgrounds. If you're overweight, that increases your risks. And then air pollution, although there's not very much we can do about that on the whole. How does asthma affect the lungs? Well, a person with asthma has airways that are much more easily irritated than someone with normal lungs. So common triggers are viruses, which is what we see loads of. Allergens can do it. So in the summer, we can see people who've been out and they've been cutting grass and, it's just caused their chest to react with pollen. Exercise can do it. So people who've been doing loads of sports suddenly get an asthma attack. Changes in weather, particularly when it gets colder at winter, can be a big trigger, just irritates. I think we all often, if it's really cold, you go outside, you just catch your breath. Well, with asthma, that just causes your airways to completely spasm. And so that can give an airway, it can give an asthma attack, not in everybody with asthma, but with some. And then smoke and air pollution. The classic, isn't it, is deodorants in teenagers where somebody sprays a deodorant in their face. I'll just close my window a sec because it's a bit noisy. And lung irritants trigger the immune system, leading to a localized immune response. So we're talking about swelling of the airways, increased secretions, mucus, and bronchoconstriction, so tight muscles around the airways, making the airways narrower. So in an asthma attack, here's a picture. On the left is a normal airway. So nice and big space in the middle for your air to pass through. In the middle is somebody who's poorly controlled with asthma. So actually, if your background is not very good control, you may be okay from day to day when you're not pushing yourself, but you've got more swollen airways, thickened airways that mean that the diameter, the space inside your airway is much more reduced. So it doesn't take much to knock you over the edge to being a really severely reduced airway. And then during an asthma attack, you get tight muscles that are in bands around the airway that make the airway narrower. You get thickening and swelling of the airway lining, and you get much increased secretions. So it just results in a really tight, narrowed airway. And wheeze is just the noise of air trying to go through a really narrowed airway. So lots of things can cause it. If you've got a foreign body in your airway, you can have wheeze in one area of your lungs because it's blocking off the airway. But classically, we see it with infections and with asthma, where you get tight airways because of the muscles getting tight, swelling of the lining of the airways, and increased secretions. So all asthma, when we're doing assessments, we talk about an assessment of severity. And at the start of the all Wales asthma, wheeze pathway, it's not just asthma, wheeze as well, preschool wheeze, talks about severity being classed as moderate, severe, or life-threatening. Clearly, you can get mild, but mild kids aren't in hospital, so we ignore them. And then it all depends on whether you need oxygen, whether you're so breathless you can't talk, what your heart rate is, what your respiratory rate is, how severe you are. Obviously, there's slight caveats to that, depending on if you've had medicines like salbutamol before you come in. And we'll come back to that in a bit. And then life-threatening is all about if you're so bad that your chest is totally silent, you can't move any air at all, you're so tight, you're not moving air in and out, you're getting really cyanotic, low oxygen levels, that makes you really agitated and distressed. And that the guideline will say get senior help with that. Peak flow is another way of measuring severity in asthma, and we've never really been very good at doing that in hospital. And we've never really pushed it because realistically, most kids, if you come in with an asthma attack and your chest isn't very good, your peak flow is going to be rubbish. So we can tell before they even do it. You remember peak flow is when they breathe into the peak flow monitor and they take a big huff, and it's how much of their lungs they can breathe out in 1 second. And it measures, and really you need to know what their normal is, or at least what you'd expect their normal to be for a boy or girl at their age, at their height, because it's your size that affects how big your lungs are. And if it's like, half of normal, it's moderate. If it's a third to a half of normal, it's severe. And if it's less than a third of normal, then it's life-threatening. So maybe in the future, we'll get back to doing that. Because of COVID, we weren't doing peak flows at all because you don't really want someone huffing in your face if they got COVID. So we haven't been doing it. But a lot of the national guidelines talk a lot about peak flow, and we probably need to think about that again in the future, but we'll tell you about that. So how do we manage it? So there's 3 main key parts to management when someone comes in with an asthma attack or severe wheeze: oxygen, steroids, and then bronchodilators, so medicines to open up the airways and relax the muscles that have become tight. And the most common one we use is salbutamol. So from an oxygen point of view, low oxygen levels in asthma are a kind of late sign. So kids are pretty good at maintaining their oxygen levels until their airways get so tight that and blocked up that they start to struggle. So national guidelines would say that you should start oxygen in asthma if their SATs are less than 94. I know for most things we talk about 92, and it's not wrong to think about 92, but actually even before that we can start saying this is probably more severe than than we might expect if their SATs are less than 94. And we should be aiming to get their oxygen levels to kind of 94 to 98. If we're getting 100%, they probably don't need it, and we should reduce it, because there's more and more evidence that giving someone too much oxygen isn't very good for them either. In the short term, it's not going to cause any great harm. So if in doubt, whack on the oxygen, because you don't want to not give someone oxygen who needs it. But actually, once they're stable, we should be trying to wean it down. The need for the oxygen in asthma is caused by lots of different things. So it's caused by tight airways because of the muscle tightness, the bronchoconstriction, airway swelling, increased secretions, but also the infection itself. So most commonly we see asthma because of infection. And viruses cause lots of increased secretions. Bacterial infections, pneumonias cause loads of pus in the lungs that blocks off your little airways. And we're talking about the small airways right down in the base of your lungs. And if you block off little airways and plug them with loads of secretions, snot, that kind of stuff, then actually the airway below that just collapses down. That's naturally what the body does, because you're not using it, it's not working, so they just collapses down. And that's what atelectasis is called, just little areas of collapse. And you can sometimes see that on x-rays by just lots of little patchy changes. And oxygen levels may well just respond well to bronchodilator therapy and to steroids, but it can take time. So if they're only in a mild, if their SATs are kind of 89, 90 when they come in and they're not too bad, then rather than whacking them oxygen, you may want to just give them salbutamol, because that may bring their SATs up nicely. It's not wrong to give them oxygen, but actually if they're in only a little bit of oxygen, then you can probably just give them the salbutamol. Whereas clearly if their SATs are in the 80s or lower, then you're just going to need to whack oxygen on them as well. And oxygen levels are often worse. We all see it at night when they're sleeping. So they might be fine in the day, and then they go into a bit of oxygen when they're really asleep, particularly if they get to a really deep sleep, because when you're deep sleep, your airways become very floppy, and it's much easier for them to collapse down. And that's why often then things get a bit worse. And we see it, don't we, in the broncholytics as well. In the middle of the night, they look horrific and everyone's running around trying to decide what to do. And then by the morning, they've kind of improved a bit. And it's the same with a lot of the wheezers. They'll be doing quite well, and then maybe everyone will go, oh, they've taken a step back and they're now too early again at kind of 3 o'clock in the morning. And that's just because naturally that's what happens to all of us. Our lung function deteriorates a bit overnight and then gets better again. And then they wake up, they come off the oxygen, they're running around the ward, and we're like, yeah, they can go home. So it does change depending on positioning and sleeping. So from a steroid point of view, what we tend to use is prednisolone, and steroids work by switching off the immune system. So you can think in a way of when you've got an asthma attack, when you've got real irritation in your airways, it's like having a massive crowd of people and somebody starts shouting that there's a problem, there's a bomb over here, and everyone's in a panic and everyone's trying to run away and everyone's shouting at each other, and it all just goes completely mad. Whereas if you can put in some walls, if you can stop all those shouts going off, so if they're in lots of different rooms and somebody says, oh, there's a bomb, but no one else can hear them, then actually no one else gets worried about it, and so nothing happens. And that's the same kind of thing in immune responses in asthma, that all of these signals gets fired off, getting all the cells excited and irritated, and then release loads of other messengers that go flowing around, and all these cells flock and it all becomes swollen and complex. Whereas if you can stop all those messages being sent, then actually your lungs can recover, and that's what the steroids do. So they reduce swelling, they reduce mucus production, and they help with the airway muscle contraction. But they take a little while to work. So it takes about 3 to 4 hours to work. So the sooner you can get steroids in, the better, because it's not going to work straight away. So really, it's about getting steroids in straight away and then using salbutamol in the short term really regularly whilst the steroids start working, and then hopefully you can start stretching out your salbutamol. The side effects of steroids can increase your appetite. It can make them a bit hyper. It can give you candida thrush. But in short courses, and in asthma, we tend to do 3 days. It's not going to do much of that. It might make them a bit hyper, but so ideally you should be giving it in the first hour of them arriving at hospital. And that's what we're marked against in national audits. Now, salbutamol, and there's another very similar medicine called terbutaline, but we don't really use it, but you can find it in, sometimes people have inhalers that have terbutaline in. But this works on something called beta-2 receptors. And I wouldn't get too worried about it, but it's just, so there's all these little receptors in the airways on the muscles. And if they get stimulated, it tells the muscles to relax and open up the airways. So salbutamol stimulates these beta-2 receptors and it causes the muscles to relax and your airways get nice and open and your breathing gets easier. Now, the side effects of salbutamol come from the fact that although it's specifically designed to work on the receptors in the lungs, the beta-2 receptors, there are other types of these beta receptors elsewhere in the body, and they're called beta-1s and beta-3s, and there's others as well, but it also stimulates them a bit. So we all know that salbutamol, when you give it, makes the heart race because there's beta-1 receptors in the heart. It can also make them feel quite sick, and it's quite common to vomit because it causes gastric stasis. So it slows your stomach emptying down. So anything in your stomach sits there for longer, so you're more likely to be sick. It also reduces urine output, so they don't wee as much. Now, in hospital, we don't have to worry about the last point there about down regulation, but this is an important point when it comes to kind of regular management of asthma, that we know people who use their blue pump really frequently. So, you know, those kids out there, particularly teenagers who don't want to take their brown regular inhalers, they just use their blue one when they need it, and they're using it 4 or 5 times a day. The more you use it, if you stimulate those receptors in the lungs really often, then the body just reabsorbs them. It stops responding because it just goes like, oh, this is ridiculous. We can't be acting all the time, so we're just going to stop reacting. So then your blue pumps don't work as much. So then when they come into hospital with an asthma attack, they don't respond as well to salbutamol. And that's why we spend a lot of time in the clinic trying to encourage people not to use their blue pumps much and give them, say, steroid inhalers, Montelukast, all these other things we give them when they go home to stop them needing their blue pump as much, so that if they do have an asthma attack, they respond better to salbutamol. The other thing we often give is Atrovent or ipratropium bromide, and it's called an anticholinergic. And again, you know, I wouldn't worry too much about all the physiology of it, but just so you know, there's nerves that go to the muscles in the lungs that cause the nerve that send signals saying constrict, get tight. And that's what happens when your immune system kicks off in asthma. So these Atrovent is an anticholinergic, so it stops the signals in the nerves being sent to the muscles, and therefore the muscles don't get any signals telling them to constrict, so they relax and they open up. So it's another way of opening up the airways. It also reduces secretions a bit, but that's not the main way it works in asthma. The main way it works is by opening the airways, a bit like salbutamol. It's just not quite as effective as salbutamol. But it can also cause a dryness of mouth because it reduces secretions in your mouth and means you don't wee quite so much. And it can give you a bit of a tremor like salbutamol can, so they get the shakes. And it starts to work in about 20 to 30 minutes and lasts about 4 to 6 hours. So if you do see us writing out Atrovent beyond that first kind of back-to-back nebs that we do, often we'll do it every 4 to 6 hours rather than say hourly and 2 hourly like salbutamol, because it lasts much longer than salbutamol. So why do we give nebulizers versus inhalers? Well, I mean, you guys all know, if you're needing lots of oxygen, you need a nebulizer because you nebulize with oxygen. And if you want to be, if they're on a, you know, non-rebreathed mask needing 10 liters of oxygen, you don't want to be taking that off to give them some puffers because their oxygen levels will fall. So if they're needing lots of oxygen, they need to be having nebulizers. If they're not needing oxygen, or they're really borderline, so, you know, if their SATs are kind of 90, 91, then there's good evidence that giving 10 puffs of salbutamol via a spacer is as effective as giving salbutamol via a neb. It's a smaller dose, so you tend to get less side effects to it, less shakiness and all that stuff that we know happens when we give them loads of salbutamol. But if you need oxygen, you need the nebulizer. So as I say, if your oxygen level's really only just needing oxygen, you may as well just give inhalers because hopefully that will bring the oxygen up and you won't need oxygen at all. But if they're needing a significant amount of oxygen, then you have to give nebulizers. You know, in the past, we gave what used to be called SAMneb, so salbutamol, Atrovent, and magnesium. And that was after, I'll just talk about it in a sec, so what was called the Magnet trial, which Colin Powell was involved with. But we don't do that anymore because the evidence really said it didn't help. So the magnetic trial, which Colin did, so we did here in Cardiff, as well as lots of other centres. So they looked at 500 kids with bad asthma, came in with acute asthma, who weren't really responding to your normal salbutamol and Atrovent, and they gave them magnesium, or some of them gave a placebo, you know, no medicine, to see if it was just the effect of having something or whether it was truly the magnesium. And overall, magnesium was shown to not make any difference. But when they looked at children who were really sick, they did find that it may have made their symptoms a bit better quicker. and they've tried to reproduce it, and they've tried to show that actually maybe there is a cohort of kids that we can give magnesium to, but no one's really been able to reproduce it so far. So in general, all over the country, the feeling is that magnesium nebulizers don't make a difference. So it's not on our All Wales wheeze guideline. Having said that, Swansea and Newport both do it, although I heard that maybe Newport's just stopped doing magnesium nebs, but Swansea definitely still do. So if we get trainees coming from there, they may well say to you, oh, can we get some magnesium? And it's not wrong, but the evidence is it doesn't make any difference. So we don't do it. So our answer is no, here we don't do it because the evidence is that it doesn't work. So just so you know. So this is the top part of our acute wheeze guideline. So we assess severity. If you're moderate, then it's just oxygen if you're kind of 92 to 94% SATs. We're giving the steroids, giving the pred, and then giving salbutamol. I'll come back to the younger kids in a bit because we don't automatically give steroids to under 3. I'll talk about that. If you're severe or life-threatening, then it's about giving oxygen, giving you back-to-back nebulizers if they're on oxygen, or inhalers if they're not. And we put salbutamol and Atrovent in, and we do 3 back-to-back, so every 20 minutes for an hour. And then we go to hourly, and then we review things. So it doesn't matter what kind of steroids, because you know, a lot of kids vomit it, don't they? The pred we use, really cheap. So you know that the horrible stuff that doesn't dissolve very well, is it all a bit bitty and chalky, and the kids hate it and make them vomit, is worth a few pence. Whereas the really nice tasting stuff that we used to use, and the GPs give these lovely soluble tablets, costs about, I can't remember, 20 quid. So it's a massive difference when you think of how much steroids we give. So that's why our pharmacy and hospital is so keen for us to use the awful steroids that we do. Because for most kids, they're all right with it. Some aren't, and then we might try something different. You know, in the past, we've given some dexamethasone like we do with croup. And there is increasing evidence that dex probably is effective. And maybe you will only need to give 1 dose. You know, give it because you know with steroids we tend to give once a day for 3 days with the pred. And maybe with dex we'd only have to do it for 1 day or maybe 2. Obviously, if you're sending people home with dex, it's much more difficult because it comes in a big bottle, and it's very difficult to just give them 1 dose. And all of the research into asthma up until the last few years has all been around prednisolone, which is why we always do prednisolone, because we like to follow the research. But maybe in the future we'll change that, and some units are doing dexamethasone, not so much in South Wales, but some places use it as a second line, but we're not currently. Now in the young kids, so you know, you often hear us saying you can't diagnose asthma in young kids, and it's not so much that you can't, but we know that about 70%, so a huge proportion of kids under 5 who get regular wheezy episodes grow out of it. And true asthma is a chronic condition, you have it for life. So most kids will grow out of it, even if mum's got asthma and they've got eczema and all those kind of things. So we don't tend to call it asthma because there are some jobs when you're older, particularly in the armed forces, frontline, SAS stuff. Most people will never do those jobs, but some people will. And if they've got asthma in their notes when they were 3 or 2, they're not allowed to do it. So there's no point calling it asthma because we know most grow out of it. The treatments are all the same. So it's a bit like, you know, what's in the name, it doesn't really matter. So we don't tend to call it asthma. And in the young kids, the preschoolers, particularly the under 3, there's good evidence that steroids doesn't really make a lot of difference. And why that is, no one's quite sure. It's probably to do with the airways evolving and changing. So with the under 3s, the guideline would say you don't immediately give them steroids when they come in, but if they're not getting better over the first 4 hours, if they're not stretching out nicely, so you know a lot of kids come into CAU, they get their inhalers, they get back-to-backs, they go to hourly, then they go to 2 hourly, then they go to 3 hourly, and they're stretching nicely, they don't need steroids. But if they come in and they're stuck on hourlies, 2 hourlies, and they're not very well, then we would give them steroids at about 4 hours after they come. And that's because most kids don't need it, so it's just no point. But any child who's life-threatening, any child who looks horrific when they come in and we're giving back-to-backs and we're thinking, shit, we're going to have to just go straight to IV, you know, you're going to give them steroids because you're going to hit them with everything. So you're not going to worry about what their age is. You're just going to go, let's give them everything we've got. So I think if in doubt, yes, give steroids. But if the kid's getting better and they're young, then we don't tend to give steroids. So we've seen a bit from A&E where they come up and they're 18 months old or 20 months old and they've been given steroids. You know, I wouldn't do that. until we know that they're not getting better. So really, they should wait until 4 or 5 hours after they come in, which is actually usually they'll be on the ward. But once they've had it in A&E, they've had it in A&E, but we might not continue it. So sometimes you'll see we'll stop it on the young ones. So if we've given them steroids, we've given them inhalers or nebs, and they're not getting better, what are we going to do next? We're going to think about some IV treatment. So I'm just going to talk through that and why we do it. So the first thing on the guideline is about IV bolus therapy, and that's either IV salbutamol or IV magnesium. And the idea with IV salbutamol bolus, so that's a one-off shot, is that if you're really working hard, if your asthma is really bad, then even if we're giving nebs or inhalers, sometimes they're just breathing is so poor, their ability to breathe in is so poor that none of the medicine's getting into the lungs. So they're not stimulating their receptors. So they're not getting any bronchodilation and it's just not working. So if you give them an IV shot, then you'll stimulate all those beta receptors in the lungs all in one hit, as well as all the beta receptors all over the body. So they'll always get tachycardic with that. But if you hit all those beta receptors, then maybe you'll open up the airways so that the nebs start working. So there are quite a few children where you might be able to just give one shot of IV salbutamol, they improve with that, and then you go back to giving them nebs, and then they're okay. And you don't need to go on to give them more IV therapy. So it's just a one-off. It's not a loading dose for IV salbutamol infusion. It's just a bolus dose for a one-off go to see whether have we got to all those beta receptors. Magnesium is also just a bolus dose. And magnesium came from adults. So in adults, particularly in A&E, they found that giving magnesium really improved a lot of people with asthma. And there's good evidence in adults. There's not much evidence in kids. Not to say it doesn't work, but there've just not been many studies. And it's so cheap that drug companies aren't going to pay for studies in magnesium because they're not going to make any money on it. So in the guideline, we do tend to say you can consider magnesium. And I don't know what you guys feel. I've seen kids that respond really well to magnesium. And I've seen kids that we give magnesium to, and it makes no difference at all. It's supposed to stabilize cells, so it stops all those signals being fired off so that the immune response just kind of dampens down and stops getting so irritated. So there is some evidence it works, but not in all kids. So it's something we can try, but it should never stop us. If they're really awful, it's usually quite easy to draw up magnesium and to just give it. Whereas trying to draw up and measure up your salbutamol infusion, your aminophylline infusion is a bit more complicated and takes a bit more time. So often it can be one that you give whilst you're trying to sort out, say, the aminophylline infusion, but it shouldn't stop you doing that. And then the intravenous bronchodilators, which is aminophylline or salbutamol. Now recently, well, so the history is that we used to do aminophylline all the time. Way back before I was a trainee, aminophylline was what was used. And there were some concerns that it can give side effects. It can make you vomit, it can give you headaches, it can make your heart race, it can give you some arrhythmias, mostly seen in adults, so funny heart rhythms, and rarely it could cause seizures. And people who were on aminophylline infusions for many days got lots of side effects. So there was lots of concern about it. So then they came along with IV salbutamol, and that was invented, or they produced it. And they thought, oh, this is much better. So then it became much more kind of current to give IV salbutamol. So APLS guidelines will often say IV salbutamol. But actually, IV salbutamol's got loads of side effects. It definitely makes them all shake. It makes them all anxious. It makes them all tachycardic with a fast heart rate, really fast, doesn't it? It can make you drop your blood sugar. It can give you an acidosis. It creates, the way it works in the body, one of the side effects is it creates acid. And so you can become acidotic. And if you're acidotic, like our DKA patients with diabetes, they get really fast breathing and deep breathing that's abnormal. So you can actually make breathing worse if you make them toxic with salbutamol. So sometimes we'll do a gas and the gas will be really acidotic and we'll say, okay, we need to reduce the salbutamol. So then there were lots of concerns about salbutamol. So it kind of went out, well, it's not gone out of fashion, but nobody really knew whether aminophylline or salbutamol was better. And all of the studies saying which one should we use first have shown that it doesn't really matter. They're both as good as each other. So there's no right or wrong. But here, we decided some years back, well, Julian Fortin with others, that we were going to use aminophylline first. And the main reason we did that is it works differently from salbutamol. Again, don't get bogged down with how it works, but it's a phosphodiesterase inhibitor. And it helps reduce all the inflammation and helps the smooth muscles to relax, the muscles in the airways, opening up the airways. And I think his argument, Julian's, and one that most of us would agree with, and I agree, is that if you're giving loads of salbutamol with nebulizers and it's not working and they're getting worse or they're not getting better, it just kind of doesn't seem right to then just give them a bigger dose IV and make them really toxic, when you could try giving them something that works in a different way. Yes, might have side effects, but works in a different way, and see if that works first. And it's not common to get loads of side effects in the first 24 hours with aminophylline, and most kids on an aminophylline infusion go onto it and they're on it overnight, and then we stop it the next day. So it does need a loading dose because it has a really narrow therapeutic index, which means if you don't have enough aminophylline, it does nothing. If you get too much, it doesn't make you very well. So you're going to have it just in the middle, just right. So that means you need to give a loading dose to bring the levels up in the blood before you start the infusion. So it is different from salbutamol. Salbutamol infusion doesn't need a loading dose. We often give a bolus dose. That's just to see if it's going to work, but it doesn't need a loading dose, whereas aminophylline does. And we agreed that we could do it on the ward with a child on monitoring. So we decided in Cardiff, aminophylline was going to be the first choice. Now, I think in the last week, I've seen 2 kids when I've come in the morning who are on salbutamol infusions. Now, usually we would say salbutamol infusions should be on HDU. And it's not that we can't do it on the ward. They should be on monitoring. They do need more monitoring. So they should really, if they're on IV salbutamol, it can drop your potassium. So they should be having potassium measured. So using these done twice a day. So, one of the reasons we try to go for aminophylline as well is it's just simpler on the ward. So it's not that we can't do it on the ward. And if people have been happy to do that, that's fine. But we would say in Cardiff, we should go aminophylline first. And then if they need IV salbutamol, which would be the next step, then they should go to HDU to have that. So 4-hour review. If you look at the guideline, it talks about a 4-hour assessment. And this is what I try and labor away to our trainees, that sleep is really important for kids with breathing issues. They need to sleep to recover. And if they can't sleep, they just get worse. So if we're prodding them all night long, doing observations and having them on hourly nebulizers, and they're really shaky and they're really unhappy and their heart's racing, they just get worse, or at least they don't get better very easily. So the idea is that after 4 hours, if they're not getting better, if they're on hourlies still and they're stuck on hourlies and someone reviews them and goes, oh yeah, no, they still need it, then they need to think, what can we do to change things, to make this child better? And really that's about escalating to IV therapy. So yes, you could carry on hourly nebs on a child for 24 hours, and eventually they probably will get better, but they'll feel really rough, they won't have slept well, and it often makes them stay longer. Whereas if we can give them IV therapy for 6-12 hours and then stop it again, we can turn them around and get them out the door. So what we're told to do, the other thing about 4 hours is that's when prednisolone, when steroids starts working. So if you give steroids when they first come in, they should be getting better by around 4 hours. That's not to say they're going to be perfect, but they should start to improve. And if you're not seeing an improvement, then you need to escalate. So in the mornings when we're in handover, I'll say to them, okay, so what happened at 4 hours? And they're like, oh yeah, they were still bad, so we carried on with hourly. And I'll say, slap them around the heads. No, not really, but so we'll be saying, no, at 4 hours, if they're not getting better, you need to escalate things and think about maybe if they're not too bad, but they're just not getting better, maybe you put a drip in, give them an IV salbutamol bolus and see if that just works, or some magnesium. You don't have to automatically go and give an infusion, but if it's 10 o'clock at night, the idea of going on to an infusion is you can then reduce the nebulizers. So that's the other thing I say to them. If they put them on an infusion overnight, you've got to drop them back from hourly nebs or 2 hourly nebs. Try and go to at least 3 hourly, because they should get better on the infusion. And then you don't want to be waking them up as much. If you keep them on hourly nebs and on an infusion, you kind of, it's kind of a bit pointless unless they're really sick, in which case maybe they should be somewhere else like HDU. So consider IV therapy if not getting better after 4 hours. And same with 2 hourly. If they've been 2 hourly for 24 hours and they're still not getting better, I'll say to them, right, we need to do something, because if we can't spread them from 2 hourly, then we need to change it up. So no child should be left for ages and ages on, definitely not on hourly, and on 2 hourly, you can leave them a bit longer, but they shouldn't be on it all day and then all night into the next day. HDU. So, we're having a bit of a wave, aren't we, of bronchiolitis and wheeze, and there's talk that if it gets worse and worse and PICU gets full, then we might have to take over HDU and have a HDU on our ward. And I know that makes everyone a bit nervous, but ultimately with wheeze, with salbutamol and preschool wheeze, you know, what you do on HDU is pretty similar to what you'd be doing on the ward, only you'll probably have less kids to look after and you'll have a bit more space and they'll all be on monitored beds. So I don't think from your point of view, it would be hugely different. Really, we're talking HDU care if they're not getting better just on IV aminophylline, if they're needing IV salbutamol, and sometimes they'll be on both. And, you know, if they're in HDU, then we'll be able to monitor them a bit better, doing their regular blood tests. They'll be on the monitor so we can look at the cardiac and make sure they're not getting any arrhythmias. Sometimes we might try high flow with asthma. There's some evidence that that can help with older kids with asthma, but we don't do it very often. But ultimately, if they get really sick and they're not getting better on their infusions, they're going to need to be intubated. But anaesthetists will try and do anything possible not to intubate children with asthma. I don't know if you've seen it, but you know, it's very sweaty events when you can see sweat pouring down anaesthetist faces, because I have seen children arrest when they're being intubated with asthma. Because when you're working really hard with your breathing and you're maintaining they have to splint their chest, so they maintain the pressure in the lungs to try and open up the airways, and they're needing huge pressure because of their tight airways. And that huge pressure has a pressure on the heart and on the veins around the heart. And they're having to maintain a really high blood pressure in order to keep everything working and keep the blood flowing. And you suddenly give them an anesthetic and they drop their blood pressure and suddenly their lungs collapse whilst you're trying to do it manually with a bag, then they can just arrest. So it can happen. So usually when they're going to be doing intubation of a child with severe asthma and wheeze, they'll have inotropes, so something like adrenaline infusion all drawn up, ready to go. They'll have loads of fluids. So they've got you to get fluid boluses ready. So if the blood pressure drops, they can give loads of fluid, and they'll want all of that ready before they intubate. So these kids are, you know, ideally kept on the ward or stroke HDU on infusions, to the point where actually you're saying that there's nothing more we can do. We're going to have to intubate them because they don't want to they do it all the time. You know, we don't do it that infrequently, but it's always a bit of a stressful event. So they don't like doing it. So I know I've raced through a lot there, but the key points to remember with asthma management on the ward is get steroids in early. So in the first hour, definitely. Ideally, you know, on CAU would be saying, well, like they come and find us and say, can you write up some inhalers so that we can give this salbutamol, they're really wheezy, even before necessarily we've been to see them. Or they'll say, come and listen and write up, just listen before you take a history so we can crack on early. We'll be doing the same thing with steroids, because it takes 4 to 6 hours to work. That's what we've got to get in there. And then that's what we're hoping is going to work to make them better. Inhalers are just as good as nebs, unless you're needing loads of oxygen. So you're much better off giving 10 puffs via a spacer rather than nebulizers if you can. If not, give nebs, but you know, you get more side effects. 4-hour review, really important. Are they getting better? Is this child going to be able to get some rest overnight? If not, escalate, give some IV. IV bolus can be helpful without needing to have the infusions. And we use IV aminophylline first line, and then you should be able to reduce your nebulizers so they can sleep. And if we do end up running an HDU, you will have a registrar or consultant permanently on the HDU area, and the consultant around the lot. That would be our plan from a doctor's point of view. And you'd have, you know, 1 to 2 care, and it'll probably be a much more calm affair than the wards, which will be manic with all the broncholytics and all the wheezers who haven't got there. So, you know, I don't think it'll be an awful place in terms of, yes, they're sicker, but I think we'll have a better environment to manage them. So that's all I've got to say. Has anybody got any questions, having raced through that?
Hi, Dan, it's Karen.
Hiya.
I've got just a couple of questions. The first one is, there was somebody a few weeks ago who was on an IV aminophylline infusion and was reviewed by PICU doctors. And they were saying, oh, why haven't we done aminophylline levels and things like that? Now, we've looked after aminophylline for a long time. Yeah. And I don't know of anyone who'd had the levels. Is that something new or? No, I mean, technically, if you remain on aminophylline, then you're supposed to do levels. We, with pharmacy, had determined that actually the likelihood, if children get better, then you can assume that their
level is okay. And we don't usually keep them on long enough to become toxic. I suppose there is an argument that if you're on IV aminophylline and they're not getting better and you're thinking about escalating, then there are some kids that we give a standard dose to and actually their level just doesn't get to the right point. So you might need to give a bit more. So I suppose in those situations, we might send an aminophylline level, but we don't do it routinely and we wouldn't do it routinely.
Yeah, that's fine. Okay, thank you. Yeah, and the only other thing is obviously these patients need an HDU is really good, obviously, because the 1 to 2, but on the ward, they're saying now, you know, we don't get ratios and things. And it is hard work providing that care that those children who need to go on the IV salbutamol and things like that is, you know, it can be quite intense when you've got 3 other patients and things. I
agree. I don't know, you know, I wasn't here when the aminophylline decisions were made about doing IV aminophylline on the ward. I think part of the thought around that was that you needed less monitoring potentially than salbutamol, and it tends to make you less really tachycardic and all the other side effects. So that's why we agreed to do that one on the ward, or, you know, you guys, the wider nursing group agreed that that was okay. And also just because it's so difficult.
It seems like they're pushing it, aren't they?
I know.
All the time.
Well,
you know,
I think they
went
are.
from, you know, aminophylline was always HDU. Then it was like, oh, you can do it on the ward. Then it was salbutamol was HDU. Now it's like, oh, you can, if it's the lower dose, you can do that on the ward.
I think realistically, it is a lot about pushing it. That if you were in one of the DGHs and you put someone on IV aminophylline, you would be in their HDU environment because the general peds manage the HDU, and their HDUs are not at the same. Our HDU is much more stricter admission criteria than if we were, you know, when I was in Swansea, if I said someone goes on HDU, you know, they go on HDU, they don't have to meet X criteria that the PICU consultants will want us to meet. So I think a lot of that was that we just couldn't get people up there, and what could we do safely on the ward? But it is safely in the sense that it, you know, it is more on you guys, definitely. And I think most of our kids with aminophylline, once they're on the IV aminophylline, they're much better. But it does mean lots of monitoring and keeping a close eye. And I don't know, you know, what has been agreed from your nursing ratios. But I think that's why I was quite surprised to find a couple of kids who've had IV salbutamol, because my understanding was that we had agreed that that would always be HDU. It's not that it's inappropriate to do that first line, but it just is, you know, traditionally is more work even than the aminophylline. But I mean, that's a bigger political thing, Karen. I agree. It's tricky.
I know.
And it is all about here and our lack of HDU capacity and difficulty getting them onto HDU.
And one last thing, sorry, then I'll give somebody else a chance. So, you know, the protocol is for over 2s. Well, obviously there was a patient last night who came in who was only about 15 months, but had a very acute onset of a wheeze, had had a previous history. So we did go down all the IV and he did respond. So can we, so the Reg wants to follow that?
Yeah, so I would say that's fine in the sense, so it's a guideline. So we know, you know, we're just very aware that the 1 to 2 year group, as you know, is really tricky, isn't it? Because a lot of them have got bronchiolitis. And, you know, sometimes we as the medical team smash them with loads of salbutamol saying, oh, I think they're getting better. Yeah, I think they're responding, but no, they still need hourly. And eventually someone kind of goes, actually, do you think this is working? And we stop it and they're no different. And we're just not making them horribly tachycardic and shaky, and they're better off not having it. So I think we're always very wary of saying under 2s that you could automatically put them on a salbutamol on the pathway for wheeze, but it's not that it's unsafe to do that. So I think as long as somebody's made a really good judgment around have they got better with salbutamol, they're convinced they are, then yes, they could go down the wheeze pathway. Particularly, I think if they're 18 months to 2, I think personally, I think under 18 months seldom respond, but there are some. And we've had a 14-month-old, I think, wasn't it, who had been in multiple times, definitely responded to it, inhalers, as in went a good hour after inhalers without needing another one, but was kind of stuck and then went on to IV and did very well on it. So you can do it. It's not unsafe to do it. We just want the trainees to think really hard in that age group, because otherwise they all get hit by loads of stuff that they don't need.
Yeah, okie dokie. Thank you. That's me then. Thank you.
Anybody else?
Oh, hi, it's Vicky.
Oh, yeah.
Hi, I just wanted to take up a point that Karen just made really about the aminophylline and toxicity levels and what have you. I'm just pondering really, because kids are getting heavier And I remember a couple of years ago on Jungle, we did have somebody with aminophylline toxicity, simply because he was about 12 and about, I don't know, 100 kilos. That's a joke, but obviously a lot bigger than he should have been. So
yeah,
I think the dose, isn't it, to be prescribed at their ideal weight rather than what its actual weight might be?
Yeah, I think it's, yeah, it comes back to all the issues with overweight kids, and you're absolutely right. You know, aminophylline, like other meds, actually can be issues if you have a child who's massively over what would be their ideal weight. And it does also depend on their age. So the younger the children are, the more difference there is between how the kind of water contents and fat contents of a body compared to an adult. So you move away from, yeah, it becomes more of an issue. So I think if you've got an overweight 15-year-old and you go by their proper weight, that's probably going to be okay because they're more of an adult makeup. Whereas if you've got a really overweight 6-year-old and you're hitting them with doses based on their weight, which is more like an adult rather than the 6-year-old, then you may well come into trouble, into problems. So yeah, I think when we're using more potentially toxic drugs and antibiotics and things, we'll often think about in a really overweight children, and it's usually kids who are really obese as opposed to just a bit overweight, because loads of kids are a bit overweight. Then we should think about either taking the average for their age group, so yeah, like the 50th centile, or sometimes people say you can use the kind of upper centile, so the kind of 91st centile, but not their actual weight, but actually adjust it.
Yeah.
But the difficulty is there's no clear absolute guidance that's come from anybody nationally to say when you should do that. So it is tricky, but mostly the pharmacists will say, if they are, these kids who are really obese, you do really need to think about it. So I think bringing that up, if you're looking after a really obese child, then saying to the doctors, actually, should we be adjusting, and bringing that question up so that people think about it, and then maybe they'll just need to discuss it with a consultant because it's quite variable.
Yeah, it's just something that's stuck in my mind. Yeah, thank you.
No, it's a good point. Anyone else? No? Fine. Great. Hopefully that was helpful, guys. You can always ask me in future if you've got any other questions. And, try and keep those doctors in line. They come from all over, don't they? Do all kinds of weird stuff.
You've got to watch them sometimes,
Great. All right.
Thanks,
cool.
Dan.
Take care.
Yeah,
Thank
Bye.
you. Bye.